It is an honor to present for this audience who cares so much about the people. The last three presenters have talked to you about the tools you will need in your effort to persuade educate policymakers about evidence-based policy. Now, I'm going to tell you how to use those tools. I come from a different world from y'all. I was a practicing anesthesiologist for over 35 years. The bottom picture is me with some of my medical colleagues at one of the Northside outpatient imaging positions. I am also been very active in organized medicine, especially Medical Association of Georgia and the AMA for over 25 years. It's only been in the last years that I've transitioned from being a full-time health policy full-time practicing anesthesiologist to a full-time policy researcher. And that top slide is a picture of me with the chair of our economics department, John Martin, two of our great graduate students who are here, Ola, Yusuf, and Taj Singh. So, this is war. And that is my favorite line of any talk I have ever given. Now, this war is not like wars that you're familiar with. This is not like the war between Ukraine and Russia. In this war, you are trying to persuade your opponents to join your team to work together for a common good. And then you're trying to get your new recruit to get members from this team who are opposing you to come over and join your team to work together. And oftentimes the hardest thing is to keep this diverse group together. The best example I have is the founders of our country. It only took them 6 years to form the United States after England gave us our independence. But it took a civil war and the loss of 700,000 lives and the destruction of the Southern economy to keep that diverse together. That's,
Use a keyboard.
well, I don't have a keyboard.
Pull up tray.
What tray? I was doing so well. I need help. It's false.
Someone knows what they're doing.
I tried this, it didn't work. All right, thank you. Should I stay a little closer?
No, it's just a setting.
Okay. Okay. This is a picture from the Great Courses website. They offer college level courses on all these subjects from art to science and economics. They offer courses on military strategy. This is my favorite course. It's on a book written by Sun Tzu in the 3rd century called The Art of War. And we use, and I'm going to say, we use these strategies in our effort to get an evidence-based healthcare policy advanced. We chose the right battlefield, we recruited spies, and we did flanking maneuvers. And more about those strategies and others later. Okay, there are two components to this talk. One is educating policy leaders, and another is advocating for a policy. So when I got my adjunct appointment at the Andrew Young School, the then outgoing dean and incoming dean met with me and said, Florence, we want you to educate our policy leaders. It's evidenced by this workshop. But they said you cannot advocate as a faculty member. When you advocate, you have to speak in your role as a physician and as an individual. That's exactly what I did when I had to testify for a Georgia House study committee on a healthcare policy bill that they were considering passing. So when I gave the first part, I gave a summary of the evidence. I spoke. Now I'm speaking in my role as an active professor at Georgia State, and then when I was advocating for it, I said, now I'm speaking in my role as a physician. So that was. If you have any questions about what you can and cannot say, I recommend that you talk to your institution. Okay. Now, my examples of how, the successes that I have had at advancing in evidence-based medicine come from the fact that I was on teams that were able to advance CANDOR, which I'll explain in a moment, at the hospital level, the state legislative level, and the National Medical Association level. All right, so what is CANDOR? CANDOR stands for Communication and Optimal Resolution Program. The program is a patient safety and wellness program. So for decades, our defense attorneys told us, healthcare providers, that when our patients suffer a bad outcome, you cannot talk to your hospital or your colleagues. So they don't know if there's a problem. They don't know if there's an error that needs to be fixed. So the error just keeps recurring and hurting future patients. And worse, we are told we can't talk to our patients or their families. So they don't know what happened. And they almost never get any financial help if the medical error caused injury. CANDOR, it's just the opposite. The CANDOR, the hospital says, you have to tell the truth about what happened to your patient. Have to tell the truth. And not only that, but they tell their staff, you need to tell us when you see an unexpected bad outcome and if you see any witness errors, medical errors. And then they have teams to investigate and find out what happened. Sometimes it is a medical error, other times it's a known complication from that procedure. Then they go to the patients, they tell them what happened. They apologize if an error caused injury. They tell them what they're going to do so it doesn't happen again, and they offer compensation if the error caused injury. Now, as most of you know, advancing evidence-based policy is very hard. And I have had, as a physician, I've had personal experience with it. They did a study. All national medical societies give practice guidelines to their members about treating a disease. And every so many years, they update their guidelines based on new evidence. There was a study in a high impact journal that showed it takes from the time they these specialties gave their new practice guidelines that the physicians adopted them widely. 16 years. There's been a science that's developed around this to see why something becomes adopted. How does it become adopted faster? And why does it never become adopted? And we call it diffusion of innovation science. It started over hundreds of years ago with sociologists. And the bottom line, there are 5 basic steps on how teams do it. So let me go over them briefly. Okay, my example is going to be the 6 state teams. They got their states to pass a law to make it easier for hospitals and physicians to use CANDOR. Okay. And so first you have to know what are the concerns and the goals of each stakeholder group that are impacted by the policies. And then CANDOR bill is in essence a tort reform malpractice. So, what do the physicians and hospital leaders care about? Physicians being sued is one of the most traumatic things in their career. They want to be sued less. Hospital leaders, being sued a lot is real bad for the reputation, so same thing for them. Plaintiff attorneys tell me that malpractice cases are the most expensive civil suits there are. They are so expensive that they lose money only if the injury is egregious, where there's a potential of $1 million compensation or more. They want to decrease the cost of resolving these issues. I know several of them tell me, Florence, I have had to turn down 99% of the patients who come to me asking for help. They won't ask help more people. Patients, they want to know what happened. And they want financial help if a medical error causes injury. Now, all of them want improved patient care. So we focus it on what they care about. So, as I said, physicians and hospitals, then you focus your message on what they care about. So as I said, decrease suits to the physicians and hospital leaders. We also say we have evidence that that because, oh, and I forgot, CANDOR also, they established a peer support group for their healthcare providers who can be devastated because instead of helping their patients, they injured them or even killed them. We kill patients. That's just a fact. And that's on my medical suit. So we have help for them. So we've got evidence that there's less burnout if they use CANDOR. So hospitals and physicians love that too. Now, attorneys and patients, we say, hey, we're going to tell you the truth. And, we're going to give you compensation for that error, even if it's a little chip $2,000, you get it. That would never happen in the previous practice that we, when they say keep the mouth shut, which we call deny, delay, and defense. So, okay. So, when you got to get your other stakeholder groups involved, supporting. So you have to identify a peer opinion leader of that stakeholder group who will champion the policy to his group. You don't do it, they do it. And that has been the most challenging thing of these 5 steps that we've had in our state. Remember I told you we've used Sun Tzu strategies? Well, here's what we really used. Like, for instance, we had a stakeholder group who was opposed to CANDOR bill. So we invited the leaders to a really nice restaurant, fine dining, great wine. We got to meet each other socially, talked about problems we had with all of us having denied the land of them. And then we talked to them about, well, here's the benefits of CANDOR. This is really in there. And I mean, that was so impactful. We got it. Now, another time, we had a leader of a stakeholder group who was opposed, and he told us what he was opposed about, and we addressed all his current concerns. And he's still opposed, and that was not why he was voting against it. So we recruited a spy in his group who went and found out what he was really upset about, and then he reported back to us. So we were able to address those issues. That helps. And the third time, it was the leader of the group wouldn't budge. I don't care. No matter what we said, no way. So we did a flanking maneuver, and we were able to find somebody a little higher up than him, leader, to take over the negotiations and convince his group to support CANDOR. And that's how they got the bill really going, and that's what got it passed. Now, I'm telling you, I do not go to that stakeholder group, that peer the champion is. But you want to help them communicate. Now, that document on the left, don't read it. It is just, I want you to look at the form now. First, it's in 10th grade reading level. Just keep it basic. Those are bullet points. There are no references and there's no figure. The bottom line, what we say is, y'all, it improves patient care. We're going to tell you the truth and equal access to justice, because even the minor injuries, we're going to pay it. Error. And we've got evidence that it decreases healthcare provider burnout. Now, and I think it's really good when people want that. We need more data. We have a 2-pager. 2-pager has references and it has figures. And I'll never forget, my favorite though, was we had a senior leader in a large healthcare system who wanted his hospital to do it. And so I really prepped him, gave him a lot of the papers, a lot of the research. I gave him my slides about, when we looked at what happened with when Erlanger Hospital in Chattanooga implemented CANDOR in 2009. So he presented that, all the slides, and I wasn't anywhere near the place. They wouldn't trust me, but they trusted him. And this was to the C-suite. And they decided to adopt it. So that was really good. Now, fifth stuff they talk about is you need to get external help. And for us, that meant national medical organizations. And besides the Medical Association of Georgia, we got the American AMA and Institute of Healthcare Improvement, which is the Patient Safety Foundation that Don Berwick started decades ago, and their Collaborative for Accountability and Improvement, which I'm on their policy. And the reason why you want to get help from other teams is they have different expertises that our team or the CANDOR Coalition don't have. We're seeking help. They have resources we don't have. So it's that collaboration of many teams with many specialties that help us. And I am going to speak more about being on a team and a team leader. Now, one thing the diffusion of innovation say is there is one deal breaker, and one of our teams found it out hard way. They had a grant from AHRQ for over $2 million. I think it was even $2 million to get CANDOR implemented 2 large hospitals and 5 outpatient surgeries. Didn't do it. Totally bad. Just people say it's a waste of money. Well, it wasn't. They wrote a paper on lessons learned, and their big takeaway is they did not get a physician leader or a hospital leader to champion it to their stakeholder group. And so then a few years later, they were having to implement it at Beth Israel and Bay State. First thing they did was got their champions, boom, and that's been very successful. Now, as a health policy researcher, I know the numbers. I know the number of the data. I know the numbers of the people who are hurt by bad policy and by healthcare practices. But it's as a physician, I see the faces of the patients who are hurt and who die because of these bad healthcare policy and practices. That has been the impetus for me to work sometimes enormous amounts of hours that it takes when you're doing this. You have to do great research and then getting all this other, it's a lot of work. So, and you don't have to do it all. That's the first thing I'm going to talk about briefly. But think about what makes you passionate, because those are the things that will get you working until midnight or up at 5 in the morning. So, okay, when I say do your homework, I mean do your homework. Famous economist said that countries had changed their policies based on his research. And I'll never forget, he said, Florence, if you make a medical error, you will kill one person. I make an error, a data analysis, entry, interpretation error. He said, I can kill hundreds of thousands. And he said, that is why I spend so much time looking for my mistakes. And also, he gets other very good people to advise him on the research study and the analysis and interpretation. If you're going to do this, if you're going to think about it, how would you feel if the policy that you recommended was adopted, passed, and then you found out it's based on flawed data, and you killed people, you hurt them, so help them. So, this is not for slackers to do this. It requires work, finding your mistakes, and it's not for you working alone. You need to seek help, not just from your research advisor, but from many other people and experts on that. Okay, now going down to the granular level, you need to know your strengths and weaknesses, what you need to compensate. All right, my strengths. I am a very good salesman. I come from a long line of good salesmen. The problem is, as my father lamented one time, that sometimes he's such a good salesman, he sells himself and others on bad investments idea and will lose a lot of money. Now, fortunately, Dad lost more money than anybody, so they never accused him of a Ponzi scheme. but that is why I and advocates need you to tell us if what we're advocating for is evidence-based. I'll never forget, I had a physician come up to me and say, Florence, we want to pass a vaping bill. Can you help us? I don't think they. So, but I knew someone who did, Mike Pesco, who's a national expert on this. He was at Andrew Young School. So I put them together, and the following year, they passed a very good vaping. Another time I had legislators come up to me, say, Florence, we want to pass a gun control, one of the mitigation bills in some of these other states. We have the stores, but we don't have the data. Do you have the data? Is there any evidence that any of this stuff worked? So I have spent a year trying to find it. And unfortunately, so far, we don't have enough evidence, enough time to see what works and what didn't of these states that are doing it. Let's see. The other board. Okay. The other thing is I'm a good team player, and I'm also well trained in conflict management skills. More on those later. All right, now I'm quickly go through my weaknesses. My knowledge base, I'm a doctor. I'm not an economist. Fortunately, I work with great economists and health policy researchers, learn from them. And they learn from me too, because I know a lot more about the healthcare world than they do. My speaking skills, I started out being terrible. I was going to have to present in a webinar, and it got 15,000 views. And one of the organizers said, Florence, I think you'd really benefit from getting Mimi Bliss, who is a professional communication teacher session with her. My department was so impressed with my improvement that since then, for several years now, they have hired her to give their graduate students going on the job market 2 sessions with her to help them prep for their interview with their employees. My writing skills never made a C and never made it A, so I get help. Katie has helped me, and Jennifer and others, and they've taught me. I do not make schools. I'll never be on Swabish. I don't have time to really get down into the details. Because I've got good funding, I hire Michelle Murakami to handle. You want contact information on them, just let me know and I'll give it to you. Okay. Know your audience. This is what Katie was talking about. It's true in speaking too. Shakespeare wrote all the world's a stage and all the men and women merely players. You know, Raphael Boswick told me, he is president of the Atlanta Federal Reserve Bank. Atlanta, he said when he first came, yeah, he was trained in communication and he said, Florence, there's tone. He says, I say one thing, I say something in one tone. And then if I said it in a much more excited tone, business analysts interpret it differently. So there's very, very specific. Another thing about communicating is that a savvy politician said that in order to get bills passed, you need to give them data and stories. And the interesting thing that we found out, Edward Glaser, who's chairman of economics at Harvard, said there are some policy leaders who are more swayed by data, stories, and others by stories. He said you have to give both because they're going to need both. But and he advises politicians sometimes. The example is he, you know, for Obama, you know, Obama's very data-driven, so he really emphasizes data. Gives the stories of data. Biden likes the data, but he loves the stories. So that's very important. Know your audience. There's not time to talk about speaking. This is another course, a great course on how to do it and use this with Media Bliss. They have intermittent sales, 70% off. If you purchase this, I recommend it. Okay, it's feedback, just like they said. I use it all the time, and it works very well. All right. This is my most important slide. In order to be a successful, it takes a team, and a team with different expertises, and you have to collaborate together. Probably the biggest reason why I have been successful is I am a good team player. This is my second most important slide, and I alluded to it with John. There's always going to be conflict in a team. How you manage it will be the difference between success and failure. And not only does, if you take this course, if anything you do, this is the course that it not only helps you with being successful, advancing in business, it'll help your relationships, marriages. It sure did help my husband. My husband had a big fight about the color, painting the color of the wall early on before we did it, white versus green. So we did conflict management, got it resolved. We work together as research colleagues, but I'm a physician, he's an economist. And we have different perspectives, we have different vocabularies, we have words that mean different things in our world, same word, different definitions. And what we found is by using conflict management, we were saying the same thing. So that has made us very much more productive in our effort to save the world. So I strongly recommend it. All right, last thing. I'm not going to sugarcoat this, y'all. I have failed and failed and failed. But with the help of others and evidence-based practice medicine that helps improve resilience, I've been able to pick myself up and try again. That is the essence of resilience. I do not have time to give the specific techniques I was taught, but if you want to come by, I'll tell you what has worked for me during any of the breaks. So again, y'all, it's an honor. You guys care about helping others. I want to thank you and thank you for giving me the opportunity to talk.
We have time for a few questions. Everyone?
Okay, I guess everybody's ready for lunch. I have a quick question. My obstacles, anybody else, face, what other obstacles in your effort to persuade people to do your policy? I would say, Katie, I mean, what do y'all do with that? I mean, what other obstacles besides, mine's the champion, that's been my problem. But do y'all have any particular different obstacles or anybody else in their efforts at the local level, especially? Oh, good, here we go.
Now, I would think, from my experience and from yours even more so, if you would elaborate on dealing with physicians, are, I think, particularly challenging of,
Yeah, I hear the stories of people, researchers who end up working with physicians. I've seen it so many times. Arrogance kills. It's one thing to be confident, but when you think you know everything, your people are intimidated, they won't tell you, then you just proceed to kill the patient. You've got studies on that, Jim and internal medicine. And I have heard researchers say they hate working with physicians. You really, in healthcare, you really do need to work with us because we have to know stuff you don't. I got that data. That's very sensitive data from early. My colleagues could never, they would have given it to a finance, so I didn't know what to do with it. But the thing, there are people, one person who works with group at Northwestern said there are some physicians who are not so arrogant. They listen to her and she's been very productive. Others, that way. I try to find out who is good and who we respect. It's an act of professionalism. And this has been a big, and to be honest, anesthesiologists are very professional. It's our surgeons that we're having to take the voice. I'm not biased. But yeah, the physicians are for Harvard. Yeah, I think we're more arrogant than economists. Wouldn't you say, Tom?
Sure.
Close. Any other questions? Y'all ready for lunch? Oh, here we go.
I was thinking about in the last presentation also, a challenge could be like, and I think this is true in medicine. Sometimes there is no disagreement about the facts, but like the inference that two people can draw from the same set of facts can be different, right? And like, I think doctors sometimes will say, okay, we agree on what, symptoms the patient's showing, and one doctor will say, well, I think we should treat them this way. Another doctor will say, we should treat them that way. Or two economists might look at some, some data about the economy and say, well, this is the policy I think we should pursue. And another would say, no, I think we should pursue this other policy, even when they agree about the facts.
And physicians, I can tell you, one of the problems, you follow practice guidelines. And a lot of times you do, but some of these things are very homogeneous. There are things I know this patient has been poorly diabetic controlled, or she's not doing this, or I've had her for 40 years, or she doesn't have the social support. So I'm going to do this. I don't always follow practice guidelines. I usually do, but I know things that they don't, so that may change it. I may know things they don't, and of course they don't agree. Now, as an anesthesiologist, I'm very lucky because ultimately the anesthesiologist has total control. Because if I tell the surgeon, the nurses, the cardiologist to jump, it's because the patient's trying to die. So, and if they don't obey me and the patient dies, it's their fault. But of course, if the patient does die, it's always, anything happens, it's my fault. So, but, so it's different in different worlds. It's real acute though for us. And we learn, whereas your policies can take 10, 20 years to find out he was right, wouldn't you say?
Okay, my question is more on a personal level. So for physicians who aren't trained on CANDOR, because you had that slide that for a long time, attorneys told physicians, be as quiet as possible. So for the physicians who don't follow that model, for the patients or the average person, what would be your recommendations on how to approach their doctors and physicians to be a little bit more forthcoming with information that may help them make better decisions?
Yeah, well, they're petrified by suing, stresses them out. We've killed ourselves. We destroys marriages from being sued. So, I mean, there's a reason. It's not just because we're trying to cover our butts. But the thing is, our efforts, we've got 800 hospitals who have either are implemented, or trying to implement. CMS has said, you're taking too long because it's voluntary. So they now have proposed, and we finished our public comments back in December, and they're suggesting that all US hospitals, CMS, all US hospitals have to use a form of CANDOR or they cannot participate in Medicare. Talk about the number one. Now, if they do it, I don't know. We're trying, but but if that's the case, then if they do that, you say, well, then you don't get paid for Medicare. I mean, nicely, or go above them and let them, don't you do it, because you don't want them, to get mad at you and not be your patient. So, thank you.
All right, thanks, everybody.